All right, so I'm going to get started. So we're going to talk a little bit about atypical uses for peritoneal dialysis. So just as a background, obviously worldwide hemodialysis is the most common form of dialysis, and it's typically used for kidney replacement therapy, but it's also used for other indications such as toxin removal. But more recently, there's been kind of a renewed interest in PD, both for renal and non-renal indications. So there are a lot of uses for PD that are non-renally related, but I'm going to focus on three specific areas so that my talk isn't like 2 hours long. And they're going to be peritoneal dialysis for heart failure, liposomal supported peritoneal dialysis, and peritoneal dialysis in acute stroke. So the first one I'll talk about is peritoneal dialysis for heart failure. So just brief background, we all know that heart failure is a major cause of morbidity and mortality, as well as an important cause for frequent hospitalizations. And as of 2020, appears to affect about 6.5 million patients in the US, which is pretty crazy. And the mainstay of management for these patients is medical. So ACEs, ARBs, beta blockers, but then symptomatic management is typically via diuretics. We also know that patients with heart failure can often develop worsening renal function and diuretic resistance. And so in these patients that have this worsening renal function, there's been kind of since the early 2000s an evaluation of the use of extracorporeal UF to help decongest these patients. So the three kind of main trials that this is based off of are Euphoria, Unload, and Caress HF. And these looked at like actual or like ultrafiltration. And the end result is sort of a mixed bag. So initially, the Euphoria trial in 2005 looked at patients who had heart failure and a creatinine greater than 1.5, but were not end-stage renal disease, or were technically determined to have diuretic resistance. And they were started on UF first, and then that was followed by diuretics. And their outcome showed that early UF reduced hospital length of stay and readmission rate. And so that was kind of encouraging, but then there's been some criticism with that trial, meaning that like their definition of diuretic resistance was pretty minimal. I think like their diuretics that they were using were like 80 PO of Lasix BID, which, you know, we use much higher doses these days. So there was some flaws in that design. And then the Unload trial followed up in 2007, where they looked at 200 patients with heart failure, and those patients either got IV diuretics or UF for 48 hours. And again, the outcome showed that the UF arm had fewer hospital admissions, greater weight loss, and no benefit in mortality or kidney function. But again, this study was sort of flawed as well because they didn't really include patients with like actual renal dysfunction. I mean, they didn't have like a criteria to include people with renal dysfunction or diuretic resistance. They just essentially excluded people whose creatinine was greater than 3. And so the average creatinines in these patients is kind of low. So it doesn't really get at the population as well. And then Caress HF came out in 2012, and this was a randomized control trial looking at 188 patients who either received ultrafiltration or stepped drug therapy. And what they found was that ultrafiltration had worse kidney outcomes compared to the stepped drug, and no difference in weight loss and no reduction in hospital readmissions. So that was kind of where we were left with. And so because of these findings, people started being a little bit more interested in the use of peritoneal dialysis for these patients. So the reasons being are that it's hemodynamically well tolerated. There's less risk of myocardial or renal stutting. Generally, patients on PD have better preservation of their residual renal function, which we know is important prognostic indicator in patients. There's less neurohormonal activation with peritoneal dialysis, and it can be done daily and at home, which is important for reducing the rates of readmissions. So there actually have been a good number of studies in the use of PD for heart failure, but unfortunately, they're almost all observational. So there was a meta-analysis done of all the studies in 2020, by Chion et al. And it was entirely observational studies. And what they found was that based off that, PD improved symptoms, reduced hospital admission and length of stay, and improved ejection fraction in patients. And I will say that RCTs have been trialed, and like if you look at clinicaltrials.gov, there are like a number of RCTs that have been started but then were discontinued, and that's predominantly a lack of enrollees. But there are people who are trying. So I did find one randomized controlled trial out of Saudi Arabia. And this is kind of interesting. So this was the use of tidal peritoneal dialysis versus ultrafiltration in type 1 cardiorenal syndrome. And so basically they had patients who had, or 88 patients who had acute heart failure with worsening renal function, which was essentially defined as a bump in their creatinine greater than 0.3. Who were either treated with ultrafiltration or tidal peritoneal dialysis like right off the bat. So neither arm received diuretics. They were just started on either PD or UF. And it was kind of intensive. So the PD was 1.5 to 2 liter exchanges with 70% tidal volume with 12 to 14 exchanges a day. And the UF group got SCUF with UF rates of 75 to 120 mils per hour. And essentially they continued the study for 120 hours, but the patients were continued on these modalities essentially until they were like clinically euvolemic, and ultimately were mostly discharged on oral diuretics. So the primary outcome that these patients were, or that was studied, was a change in creatinine and a change in EF at 72 and 120 hours. And then secondary outcomes were the weight loss and gain, urine volume, the rate of clinical decongestion, and dyspnea scores up to 90 days post-discharge. So these are some of the outcomes. It's not super surprising, but the creatinine they had a higher increase in creatinine with the UF group versus the PD group. So the UF group had an increase by about 2.4, and then the PD group had an increase by a change of about 1.4. So there was less bump in creatinine with the TPD group. And then below is the graph for the ejection fraction, and it showed that over time at 72, 96, and 120 hours, there is a significant increase in the EF in the PD group versus the UF group. This is the evaluation of the weight loss and the readmissions, free from hospitalization. So initially in the up to 120 hours, there was a significant improvement in both weight loss and fluid loss in the PD group, but this is not maintained. So at 30 to 60 days, you kind of lose that benefit. But the PD group overall had a significantly shorter length of stay in the hospital, and then also had less hospital readmissions. So the takeaway from this study, which looked at tidal PD versus UF, is that they had improved changes in serum creatinine. And I put a little asterisk by that because it kind of leads to one of the limitations, which is that one group got dialysis and the other group got UF. So take that with a grain of salt. And then there was an improved median ejection fraction in the tidal group, which had a 36% versus 50% at 120 hours, but it was significant at each hour. And then there were greater net fluid losses and weight loss in tidal PD, shorter length of hospitalization. And then in terms of the adverse events, there were actually more adverse events in the UF group. They had significantly more catheter dysfunctions than the PD group. And then also, obviously, they had a lot more hypotension than the PD group, which might be expected. And then one of the other limitations is that this center in Saudi Arabia, I think, uses PD pretty regularly. So they're very accustomed to it. They're very used to like putting PD catheters in very quickly. So may not be as applicable in the US. Then I'm just going to talk briefly about, so that's one of the randomized controlled trials. There are other modalities that are sort of being looked at for improving volume in heart failure patients. And one of these is the use of zero sodium dialysate. And so these patients, they created a dialysate that's 10% dextrose, zero sodium. And they've done just like very initial studies in porcine models to basically kind of prove their effect and show kinetics and see if it's tolerated. So it's generally well tolerated. And after 2 hours, they found that the zero sodium had a UF of 0.9 liters and 4.1 grams of sodium removal. And then at 6 hours, it has continued removal. There's not like a peak removal and then reduction. It kind of continues to be removed, which is interesting. In humans, so then they applied this same dialysate to humans. They looked at 10 ESRD patients and they compared the zero sodium dialysate to 4.25% for a 2-hour dwell. And so after 2 hours, the zero sodium had significantly more sodium removed than standard dialysate, so 4.5 grams versus 1 gram. And generally, it was very well tolerated. I think one person had maybe some cramping, but there was no significant removal of unintended electrolytes like potassium or magnesium compared to standard PD or even compared to diuretics. So yeah. So that's kind of the heart failure. I think it's kind of an interesting area for the use in PD, although I had, when I looked at clinical trials right before we signed on, I still don't see any like new RCTs coming up for the use of heart failure, but it's kind of an interesting area for peritoneal dialysis. So that kind of brings me back to our outline. So I'm going to go into the next portion, which is the liposomal supported PD. Okay, so background. So what do we know about liposomes? So liposomes are these very small molecules. They're nanometric, spherical, self-enclosed molecules that are made up of a phospholipid bilayer, and they have an aqueous hollow center. So they were originally designed for drug delivery. I think they've been used in like doxorubicin before, where that aqueous center basically gets loaded with a drug. But more recently, they've been evaluated as scavengers for both endo and exotoxins. And the reason they're looked at for that is because they're synthetic molecules, the pH of the aqueous center can essentially be adjusted. So you can make it more acidic or more basic, depending on what you're trying to trap. So a very acidic core will essentially protonate a basic molecule and prevent it from exiting out of the liposome. So they have been used peripherally, and they are effective, but the problem is they're difficult to remove when they're injected peripherally, and they also trigger this complement activation related pseudoallergic reaction, or CARPA. And so that led to the investigation of these being used intraperitoneally, which is sort of an elegant solution because if you increase the size of the liposomes to around 850 nanometers, then they tend to be pretty well sequestered intraperitoneally. I think, over time, liposomes are typically removed by the lymphatics, but if they're a pretty good size, they'll typically stick around in the peritoneum or intraperitoneally for a good amount of time. And then there's less risk of CARPA, and that's because complement based off its size is limited in its movement across the peritoneal membrane. So this liposomal supported PD, where essentially you create liposomes and then sort of suspend them in icodextrin, it's been being looked at in 2 different ways, both for removal of endogenous toxins as well as exogenous toxins. And so the endogenous toxins I kind of grouped together as ammonia and protein-bound uremic toxins, and then exogenous toxins are verapamil and amitriptyline, among others. So just to talk a little bit about ammonia. So we know that ammonia is produced in patients who have liver failure or inborn errors of metabolism, and it can cause confusion, cerebral edema, hepatic encephalopathy. Management of this is typically, especially in our liver failure patients medically, so with rifaximin or lactulose, but it can be removed through dialysis or CRT, as we are well aware. But there are certain settings, like with infants or liver patients, where hemodialysis may not either be feasible or tolerated very well. But the good news is that ammonia is a pretty small molecule. It's lipophilic and it's weakly basic. So in this picture or diagram here, this is kind of the theory of how it might be a really good candidate molecule for liposomal supported PD. And essentially you can see that ammonia in the blood capillaries can traverse across the peritoneal membrane. It can then traverse across the liposomes and then be protonated and kind of be sequestered within the liposome. So people have looked at the use of this both in vitro and in vivo, and have found that LSPD effectively sequesters ammonia. So this first graph is a comparison of in vitro and in vivo LSPD compared to standard PD. And you can see that the ammonia dialysate concentration just significantly higher. It's 20 times higher than usual PD. And that was done in rat cirrhosis models. And then they compared it to HD as well. And HD definitely wins out, but LSPD is pretty striking as well in terms of its ability to remove ammonia. So there have been a number of follow-up studies on the use of LSPD in ammonia, and I kind of summarized them here. But essentially they did in vitro studies to ensure that this effect was maintained in the presence of human acidic fluid, which it was. They also basically put all these liposomes in the setting of other medications that are commonly used in liver patients, like Lasix or Bactrim. And it was the sequestration effect was really significantly reduced in the presence of 3 medications: ofloxacin, norfloxacin, which are competitive inhibitors for the liposome, versus propranolol. And propranolol seems to just like destroy the liposome. So it has sort of a destabilizing effect on the phospholipid bilayer. And then they did some safety analyses. So they did a metabolomics evaluation and showed that LSPD's extraction profile of common metabolites or amino acids was comparable to that of PD. And then more recently in 2020, they've done safety studies in mini pigs. And I think mini pigs have are very sensitive to allergic reactions. And so the use of liposomes in the mini pigs was good. There was no CARPA that was seen, and the mini pigs had very little systemic exposure to what the liposome is made up of, which is phospholipid and DPPC. So ammonia is kind of exciting. It's definitely, there's a lot of excitement behind it and the use of LSPD in it. There's also been some evaluation for the use of LSPD in protein-bound uremic toxins. So I have to say, I didn't really know a lot about protein-bound uremic toxins until I was reading about this. But essentially, we know that uremic syndrome is not just from urea, as is commonly understood, but there are a lot of other toxins that cause uremia, and some of them are heavily protein-bound, like p-cresyl sulfate or indoxyl sulfate. And some studies have shown that these are pretty associated with infections, cardiovascular disease, and overall mortality in our dialysis patients. They seem to, because they're heavily protein bound, the question is, how are they removed? And it really seems to be related to residual renal function. So this is kind of a schematic of the formation of indoxyl sulfate and its clearance. And so essentially you have protein intake in the gut that then is the microbiota breaks down tryptophan into indole, which then is circulated back to the liver and converted to indoxyl sulfate. And then it's filtered at the level of the glomerulus, but it also undergoes tubular secretion through the OAT1 and 3 transporters in the proximal convoluted tubule. And so you get urinary elimination. So that's important because as people lose, we know that from like the ATOMX study, that as people lose residual renal function, there's a higher rate of mortality. And it may be as a result of the buildup of these protein-bound uremic toxins there's higher cardiovascular toxicity. So standard hemodialysis and PD typically do not remove these very well. And that's because they have a high volume of distribution and they're very heavily protein bound. So there's really just a small fraction that's available to be dialyzed off. You can adjust hemodialysis to increase the ability to remove them by increasing the KOA or increasing the dialysate flow, but PD is pretty limited. So the membrane of the peritoneal membrane or the mass transfer area coefficient is pretty fixed. Luckily though, PD patients tend to retain a lot of their residual renal function. So, but it does bring into the idea of something called bound solute dialysis. So this is a form of peritoneal dialysis, or it's also done in hemodialysis as well. But it was started to look at in like the early 2000s. But the idea is that you add sort of a sink to the dialysate to encourage movement of these protein-bound uremic toxins across the membrane. So instead of doing standard like dextrose dialysate, you add albumin or you add liposomal supported PD. And because there's albumin in the dialysate, that encourages the dissociation of the uremic toxin from the protein and the transfer across the membrane and then binding to the albumin within the dialysate. So there are, in 2019, there were a few people that looked at the use of albumin-based dialysate and liposomal-based dialysate for the removal of these PBUTs. And so this is a lot of information, but the top row is serum, and then the bottom row is dialysate concentrations of the uremic toxins. So first we have p-cresyl sulfate, and this showed that at 360 minutes, liposomal supported PD significantly had lower levels of serum p-cresyl sulfate. And in the dialysate, the albumin and liposomal supported PD had significantly higher rates than the controls of the glucose-based dialysate. In the indoxyl sulfate, there actually wasn't much of a there was no significant difference in the serum levels, but in the dialysate, again, albumin-based dialysate and liposomal supported dialysate have higher concentrations of indoxyl sulfate. And in 3-IAA, at 240 minutes, the albumin serum levels were significantly lower, but both albumin and liposomal had significantly lower levels. And then in the dialysate, the albumin and liposomal supported had higher levels of these PBUTs. And I will say that actually albumin beat out liposomal supported PD. So albumin had significantly higher levels in the dialysate compared to LSPD. So kind of an interesting use for LSPD and other solute-based dialysis for the removal of these toxins. And I think it is just important. It's novel and maybe not super applicable to our populations yet, but it is at least somewhat interesting in terms of future directions for removing these toxins in patients. Okay, and so the last thing I'm going to talk about with LSPD is the use of it for the removal of exogenous toxins. So we know that there are, in certain toxin overdoses, it can be kind of challenging. Management typically involves supportive cares, decontamination if it's possible, antidotes if they are available, like N-acetylcysteine, or hemodialysis if that is appropriate. And certain situations can make the removal by dialysis more difficult. So if the intoxicant has a high volume of distribution, or if it's not as available for dialysis. So if it's really protein bound or very lipophilic. And then hemodialysis can also be challenged by hemodynamic instability. So for example, with verapamil, a calcium channel blocker, it's 89% protein bound and it's lipophilic. So that it makes it pretty hard to remove with dialysis, and there's no specific antidote. So this essentially led to the investigation for the use of liposomes, because liposomes are lipophilic and have been shown to work well with protein-bound substances. So as a background, the first study was a rat verapamil toxicity, and they peripherally injected the liposomes, and they found that the rats had improved hemodynamics and that it did scavenge verapamil, but they had some complications, mostly that it was hard to remove the liposomes once they put them in, which I think is kind of funny. And then also the rats had this pseudo-allergic reaction to the liposomes when it was done peripherally. So then they applied this knowledge and these findings to liposomal supported PD, and they put basically suspended these liposomes in icodextrin and put them in a rat with verapamil toxicity, and they found that there was a significant uptake of verapamil in the LSPD compared to standard icodextrin. So there's a greater than 80-fold increased extraction of verapamil. And then they did hemodynamic studies on these rats. And so this is also a little confusing, so I'm going to walk through it. But essentially, it shows the percentage of basal MAP after verapamil toxicity. So the blue here is LSPD at baseline in rats that do not have verapamil toxicity. And so you can see that their MAPs are pretty stable. And then the gray is after they receive verapamil but do not receive treatment. So there's a big dip in their MAPs. And then here in row C, this is LSPD that's initiated after the verapamil toxicity versus regular PD. And they had a pretty significant, I think it was 3-fold faster improved time to improving hemodynamics. So essentially the LSPD shortened the time in which it took for the hemodynamics to stabilize. And that's clarified down here in D, where you can see that the MAP recovery time was significantly shorter in LSPD versus PD or untreated rats. They have also used LSPD to evaluate other exogenous toxins. So amitriptyline, phenobarbital, haldol, and propanolol. And this is the drug dialysate concentration of these molecules. So specifically, I think haldol is pretty impressive, as well as propanolol and verapamil. Okay. So that's liposomal supported PD. So there are no human studies yet, but there's a lot of interest and a lot of people utilizing it in different ways. And I think we may start to see some human studies come out now that we have the safety analyses in the mini pigs. But I think it's kind of exciting and interesting. So lastly, I'm going to talk a little bit about peritoneal dialysis in acute stroke. In the brain, we know that there is a neurotransmitter called L-glutamate that's highly prevalent and important, and it's very tightly regulated. So it's basically maintained within vesicles in the synapses. And as a result, in the brain, the extracellular concentration of glutamate is very low, and the cellular concentration is high. Glutamate, transverses across synapses, and it can be essentially excreted through the blood-brain barrier. But the peripheral glutamate is prevented from transversing across the blood-brain barrier into the brain. So it's kind of a one-way path. In patients who've had an acute stroke and have had damage to these cells, there can be sort of this massive release of glutamate that is essentially excitotoxic. And so what they've found is that in patients there's an acute stroke, but then the large release of glutamate can cause secondary brain damage after a stroke. So they have noted that patients who've had these increased intracerebral glutamate levels post-stroke tends to correlate to worse overall outcomes. And so that led to the use of, or the investigation for scavengers of glutamate. And so one example of these is like oxaloacetate. And essentially what it does is it binds to peripheral glutamate, and that lowers the peripheral concentration of glutamate. And as a result, it kind of encourages movement of intracerebral glutamate out into the periphery. And oxaloacetate actually did show improved neurologic outcomes, but it's pretty limited by a short therapeutic window of 30 to 60 minutes and systemic toxicity. So people have been investigating the extracorporeal removal of glutamate. It can be removed by hemodialysis as well as CRRT, but especially with hemodialysis, there are some limitations. Obviously, we kind of talked about this in the M&M conference yesterday, but we're limited by big hemodynamic shifts, risk for cerebral edema, and sometimes the need for anticoagulation. But peritoneal dialysis is generally better tolerated than hemodialysis. And in ESRD patients on PD, they've shown that glutamate levels are removed by, or there's higher glutamate levels in the dialysate, and generally the serum glutamate levels are lower. So with this information, a group has taken to looking at PD in vivo rat studies. And so what they did was they induced an acute stroke in rats, and then they initiated PD 2.5 hours after the ischemic stroke. And so in this first thing, little graph up here in B, this is the plasma glutamate levels, and the dialysis is the blue bar, and it has much lower than the ones that are not treated with dialysis. And this reduction in plasma glutamate levels correlated to the infarct size. So I think these weird little red things are rat brains, which is pretty horrible, but the blue, again, is the dialysis arm. And so these patients, the infarct volume was significantly lower if they had been treated with dialysis at 2.5 hours and then also at 5 hours. They did sort of a proof of concept study where they then took the dialysate and added glutamate to the dialysate. And they showed that the plasma glutamate levels did not decrease the way that they originally did, and the infarct size was unchanged. So the benefit of reduction in the infarct size was not seen when you're not actually removing glutamate, which I thought was kind of interesting. So unfortunately, PD in acute stroke is there's not a lot of studies on it, but there is one human study, which I found, and it has a very long title, but it was done in Spain, and the information and the results are on the clinical trials website for the European Union, I think. But they're not, I can't find a paper. It's not like published in a paper, but they are on this site. So my information is a little limited here, but essentially they took 10 patients with acute ischemic stroke. They had 5 that they put in the control arm, and then they had 5 who received PD. And so within 13 hours after acute stroke, these patients underwent 6 exchanges of 2 liters every 4 hours. And the outcome was that only 1 in 5 patients received the full PD treatment. So 1 had a misplaced catheter that didn't end up into the peritoneum, and then 3 had technical problems. So they only completed 1 to 2 exchanges. But what they found was that the treatment group still had a 40% or 46% reduction in the serum glutamate within 2 hours, although this is non-significant. If they excluded the patient who had the misplaced catheter, then they did get significance in those results. And also that glutamate was detected in the peritoneal fluid 4 hours after starting. And actually the 1 patient who completed all 6 exchanges, his dialysate glutamate was 22 times higher than the others. But unfortunately, there's no significant differences in infarct volume or neurologic or functional outcomes. So the takeaway is that peritoneal dialysis may lower their serum glutamate levels in patients following acute stroke, but we're a little bit limited by technical considerations, so the ability or speed at placing the peritoneal catheter, and then the ability, like the comfort level with running PD, which really seems to vary based from institution to institution. And sort of unclear benefit neurologically. Certainly the rat studies were sort of promising, but this study was so small, it's unclear and technically limited that sort of unclear what the benefit was. So I have just a really short conclusion, but essentially peritoneal dialysis potentially has a role in non-renal indications, and we're still kind of in the early stages of it, but I think future studies like human studies in LSPD or a more in-depth evaluation of heart failure or stroke are warranted. So I'm just going to leave you with this picture. I am a big rodent fan, and I'm very generally opposed to hurting animals. And so these are two lab guinea pigs that I rescued in residency. And they can't live with me because my husband's allergic to them, but they live with my parents in Colorado Springs. And so they get to wander around and eat grass and live their best life, not being worked on. Although one of them recently died, but that's it. So, yeah, done.
Thanks, Ruth.
Yeah.
Sorry I was late, Joy. I apologize.
Thank you.
No problem.
Any questions for Ruth? So, Ruth, I think there's a question from Dr. Favell.
Oh, sure.
Just a comment on the stroke data. The rodent study applied PD at 2.5 hours. The clinical study looked at 13 hours. The timing issue is probably the major limitation. The rodent study should have looked at a more clinically relevant timing of the application of this procedure.
Yeah, I totally agree. I mean, I think that's going to be a big limitation in these patients is like how fast can you get a PD catheter in them versus like the rat study where well, you basically already have the catheter in them by the time you do the stroke. So yeah, yep.
Thanks, Ruth. Any other questions for Ruth?
No, just a comment that it was very interesting and well done.
Thank you, Brother Lau.
Thanks, Dr. Brosnahan.
Thank you, Ruth. We appreciate it.
Thank you.
Good day, everyone.
Have a good day. Bye now.